Let me tell you something most hearing clinics won't say enough. Hearing aids aren't magic. They can be life-changing for the right person and fit the right way, but for the wrong problem or with the wrong tests, they can become a very expensive disappointment. And I've watched this happen more times than I'd like. Sometimes people will spend $5,000 and wear their hearing aids faithfully for 3 months and come back still struggling to follow conversations. They assume they're the problem. They're usually not. The problem is that nobody tested for the right thing before they bought hearing aids, and in some cases, nobody ever verified what they bought was actually working correctly in their ear. I'm Dr. Layne Garrett, founder of Timpanogos Hearing and Tinnitus here in Utah. I've been fitting hearing aids for over 20 years, and today I'm going to walk you through the 4 main reasons hearing aids underperform, what's actually going on clinically, how to know if you're at risk for one of those things before you spend thousands, and what a good hearing evaluation actually looks like. Before we get into those 4 reasons, there's one thing you have to understand. Hearing aids make sounds louder. That's their fundamental job. They amplify. But your ability to understand speech isn't just about volume. It's about clarity. How well your auditory system decodes what it's receiving, and those are 2 completely different problems. This is where the phrase comes from that I hear all the time in my clinic. I can hear, doc, I just can't understand what people are saying. Maybe you've said it, maybe someone in your family has. It's clinically meaningful because it tells me the ears are getting sound, but somewhere between the cochlea and the brain, the signal is getting distorted in ways that make more volume not fix it. A review published in Trends in Neuroscience put it plainly. Hearing loss doesn't just reduce sensitivity to sound. It causes complex distortions in how the brain processes sound, distortions that amplification alone can't correct. The cochlea isn't just a microphone, it's doing intricate signal processing. When the nerve endings in there get damaged, the pattern of neural activity sent to the brain gets degraded in ways that turning up volume doesn't address. That's the foundation for everything else I'm going to explain today. So let's get into those 4 reasons, and I'm starting with the first one because this is the most fixable and frankly, the most common. Hearing aid manufacturer software programs hearing aids using an average ear canal measurement. Your ear canal is not average, it's yours. Canal volume, shape, resonance vary significantly from person to person, and those differences change how much sound actually reaches your eardrum. The gold standard for verifying that a hearing aid is delivering the right amplification is called real ear measurements. A little microphone is placed in your ear canal with your hearing devices in, and it measures what's going on at the eardrum. When that matches the prescription target for your specific hearing loss, you know the hearing aids are set up correctly. When it doesn't, you're guessing. And less than 30% of clinics routinely do this test, which means the majority of people wearing hearing aids right now have hearing aids that have never been verified. Some are underamplified and straining to hear. Others are overamplified, which causes fatigue and distortion, and they don't know it because nobody measured it. Before you blame the hearing aid, and before you think that you have to update to the newest hearing aid to hear right, someone needs to verify whether your hearing aids are actually doing the right thing inside your ear. I've had patients come in wearing 4-year-old hearing devices that had never been measured. We do real ear verifications, make the adjustments, and the response is almost always the same. I didn't know my hearing aids could sound like this. The devices weren't broken, they've just never been calibrated right for that person's ears. When I evaluate someone's hearing, I'm not just measuring how soft of a sound they can detect. I'm also testing word recognition, their ability to understand speech when it's made loud enough. We present single-syllable words at a comfortable listening level and score how many come back correctly. High scores generally mean hearing aids will work well. When those scores drop significantly, and there's a clinical threshold that starts a different conversation, around 60%, amplification alone can't bridge the gap. Not because the technology is bad, but because the auditory nerve fibers responsible for carrying speech information to the brain are too degraded, regardless of how loud you make it. When the word recognition scores drop into that range, we need to be honest about expectations, and sometimes that means discussing whether cochlear implants should be part of the picture. Hearing aids can still provide real benefit, environmental awareness, tinnitus relief, lip reading support, but if nobody has tested your word understanding scores, you don't actually know where you stand. Real quick, if you've ever been told your hearing aids are working fine, but you still can't follow conversations clearly, subscribe to our channel. I put out 2 videos every week on exactly this kind of thing. What needs to be tested, what good care looks like, and what to ask your audiologist. Now let's talk about the problem that doesn't always show up on a basic hearing test. A cochlear dead region doesn't mean your whole ear is dead. It means a specific area inside the cochlea is no longer giving the brain usable information. The nerve endings in that region are gone, and when a hearing aid amplifies sounds in a dead region, that signal doesn't get processed normally. You often get distortion instead of clarity, sounds that louder but actually harder to understand. A clinical study published in the International Archives of Otorhinolaryngology found that patients with high-frequency cochlear dead regions did better when amplification was restricted at those frequencies, not boosted. Standard hearing aid program was actively working against them. This is why a proper evaluation needs to go beyond the basic audiogram. Otoacoustic emission testing and extended high-frequency audiometry help identify where dead regions are likely present. If no one has ever looked for them, your devices may be programmed in a way that's adding noise instead of clarity, and that's a fitting problem, not a you problem. Cochlear nerve degeneration is increasingly recognized as a hidden contributor to hearing difficulty, particularly in older adults. A study analyzing nearly 96,000 ears found that poor word recognition scores that could not be explained by the hearing test alone were associated with underlying nerve degeneration from age-related changes, noise exposure, certain medications, and other causes. This is sometimes called hidden hearing loss. Standard audiometry looks normal or near normal, but the nerve fibers connecting the cochlea to the brain have been quietly deteriorating, and you don't see that on the standard hearing test. This is the person who says things like, I do okay in a one-on-one situation in a quiet room, but the second I'm in a restaurant or at a family party or the church foyer, everything turns to noise. The acoustics in a church foyer are basically a clinical stress test. Hard floors, high ceilings, and everyone talking at the same time. For someone with auditory processing issues, that environment is genuinely overwhelming, not because they're not trying, but because the neural machinery for separating speech from noise is impaired. For these patients, hearing aids can still help, but the benefit does have some limitations. And if no one has ever tested speech understanding and noise, not just hearing beeps in a quiet booth, but hearing in conditions that actually simulate real life, you may not have an accurate picture of what's going on. A thorough evaluation should answer 5 questions. Can you detect sound? That's the basic hearing test. Can you understand speech clearly when it's loud enough? That's the word recognition test. Can you understand speech in the presence of background noise? That's a test like the Quicksin or a comparable speech and noise test. Are your outer hair cells in the ear working normally? That's otoacoustic emission testing, which helps identify cochlear dead regions and other structural problems. And if you're already wearing hearing aids, are the devices actually hitting the prescription targets inside your ear? That's real ear measurements. If your appointment was mostly just a hearing test, followed by a conversation about 3 or 4 different levels of hearing aids, you did not get the full picture. Those 5 questions in plain English before you ever see a hearing aid are what separate a real evaluation from a sales appointment. Drop a comment. If you've worn hearing aids and felt like they weren't working well, did anyone ever test your word recognition in quiet and in noise and verify that the hearing aids were programmed correctly with real ear measurements? I'm genuinely curious how common that gap is in people's experience. If you want to go deeper on any of these topics, we have detailed resources available in our Learning Center. Real ear measurements, word recognition scores, cochlear implant candidacy. No email required. The link is in the description. And if you're here in Northern Utah and want an evaluation that actually answers these questions, you can schedule an appointment in one of our clinics along the Wasatch Front. The link can be found in the description as well. Thanks for watching.